everyone, we are Group 2 and we will be talking about acquired stuttering, a note on terminology by Van Borsel. The author states their intent is to recommend other terminology for stuttering occurring later in life based on a critical review of the literature on acquired stuttering. This publication focused on the different terminology for acquired stuttering, psychogenic, neurogenic, and drug-induced stuttering. It also describes idiopathic stuttering. Stuttering can occur in childhood between the ages of 2 and 5, which is referred to as developmental stuttering, but can also occur later in life where it is called acquired stuttering.
So the author discusses acquired stuttering, which is just a non-developmental fluency disorder, but he also discusses the fact that a lot of researchers tend to use the term stuttering really broadly, and that covers both developmental stuttering and acquired stuttering. There's no true distinction between developmental stuttering and acquired stuttering. Two other terms that the researchers use are late onset stuttering and adult onset stuttering. But these terms imply that the defluency has not always been there, and it also implies that it occurs at a specific period of that person's life.
So psychogenic stuttering is referred to as disfluency that is acquired later in life, which is linked to an emotional trauma or a psychological problem. Another term that was previously used for this was historical stuttering, but it was discarded due to its sexist and derogatory connotations. The author does recommend that this term is used even if a psychological condition has not been diagnosed, as long as there's evidence that the disfluency began due to a psychological problem or an emotional trauma.
Neurogenic stuttering is the most common type of stuttering and is caused by damage to the central nervous system. In the past, terms such as stroke-associated stuttering or cortical stuttering were used to specify the areas of damage, although the author does not recommend using these. It has been proven that stuttering and aphasia can occur at the same time, either as a concomitant of aphasia or as a part of aphasia. In this case, the disfluencies that occur are not involuntary, but deliberate because the patient is trying to self-correct or produce a word as when trying to retrieve a word. Two other terms described in the article under neurogenic stuttering are palilalia, which is an acquired disorder, fluency disorder, that is characterized by repetition of the same word or phrase in a rapid manner with lower volume and at the end of utterances. The next one is SAND, or stuttering associated with acquired neurological disorders, and it refers to developmental stuttering that is impacted by an acquired neurological disorder, causing the recurrence of stuttering or worsening of it. This term helps to separate neurogenic stuttering from developmental stuttering with an acquired neurological issue.
So drug-induced stuttering refers to a disfluency that occurs as a side effect of a medication. And another term that was used for this type of stuttering was pharmacogenic stuttering, but is not commonly used. However, it is common to specify the type of drug that induced the stuttering. And something that the author points out is that he feels drug-induced stuttering should not be classified under neurogenic stuttering, since it can be stopped if the medication is removed, and it can also be tested to confirm that the stuttering is caused by a medication.
Idiopathic stuttering is used in reference to adolescents and adult individuals who begin stuttering past childhood without a known cause. The review mentions the issues that arise from using the term and developmental stuttering interchangeably. It poses the problem that although the etiology is developmental, as stated by Van Riper, it causes confusion when used as a synonym with developmental stuttering. The review does not go in detail. We assume the reason is that idiopathic stuttering emerges well past the developmental age. At the same time, it should also not be used as a synonym with acquired stuttering, as there is no internal or external factor that explains its cause.
The terminology proposed by the authors is by no means an exhaustive list. Revising the recommended terms is encouraged as more research is released regarding the origin of stuttering.
The most significant ways in which we can apply this information in the clinical setting is to use it as a guide for differential diagnosis, especially in the presence of idiopathic stuttering. While the review states that developmental and acquired stuttering are often treated the same, it is important to be mindful of its nature, even more so when there's no specific cause. We conclude from the review that it's possible that this type of stuttering may be a result of prolonged covert behavior, which is associated with high levels of emotional response and requires a special level of clinical care. Lastly, we support the author's suggestion and proposing reconsideration of these terms as it will make the available data on stuttering more precise.